Hello, my name is Zeno Sparchez. I am professor of gastroenterology and internal medicine in Krishnapoka, Romania. Thank you for the organizing, for inviting me here. I will try in the next half an hour to present you contrast enhanced ultrasound of pulmonary fluid. Lung is a very interesting organ where the study of circulation is very interesting because lung, as the liver, has a double vascularization through pulmonary arteries, which are arteries with a high resistance flow, but also through bronchial arteries, which are vessels with low resistance flow. We can assess this by using color Doppler ultrasound, and you see that in pneumonia we have a vascularization through branches of pulmonary arteries that are straight vessels with a spectrum of high resistance flow with negative diastolic velocity. By contrary, in tumors, we have neoangiogenic from branches of bronchial arteries, and you see here some examples with a tumor, with the neovascularization in the tumor, and you see the pattern of low resistance flow. We know also that Doppler ultrasound has some limits. It cannot detect weak Doppler signals from tiny and low vessels, in lesions that have a higher depth. The detection of low is very problematic. The presence of tissue motion artifacts, especially for power Doppler, makes the study very difficult, and sometimes the Doppler effect on solid tissue motion is stronger than of the flowing blood, thus hampering the display of the macrovascularization. So, in fact, with color Doppler and power Doppler, we can display only flow in large vessels. When using contrast enhanced ultrasound, we have double vascularization. We have two phases. It's the arterial phase and the venous phase. But the arterial phase has two parts. The first part is the pulmonary arterial phase, so which lasts from 2 to 8 to 9 seconds. And we have also the arterial bronchial phase, which starts usually after 10 seconds. The venous phase is starting after 1 minute and lasts till 5 minutes. We should report the enhancement of the lesions versus the flattening of liver parenchyma. So we can detect two vascular patterns. This is the pulmonary artery pattern. So in this pattern we have an early and intense enhancement, and in bronchial artery pattern we have a late and weak enhancement. Let's start to see the main lesions in the lungs. Here is a case with compression atelectasis, and you have seen that we have here an early and intense enhancement because the enhancement and the contrast agents are coming through the pulmonary artery branch. But very interesting is in this parenchyma, atelectatic parenchyma, we have other lesions that lesions may be detected because they have different flow patterns. In obstructive atelectasis, you know the B mode aspect of this kind of lesions. We see sometimes a fluid bronchogram, which is characteristic. The cause of this obstructive atelectasis is a central tumor, an intrabronchial tumor, which causes this atelectasis. This tissue creates an acoustic window, and so we can assess the central pulmonary structure, and we can sometimes visualize the tumor. So when we are using color Doppler, we see the vascularization, and in atelectatic tissue, sometimes we may see monophasic flow because there is a vasoconstriction of the bronchial artery. when you are using fuse in obstructive atelectasis, we have a similar pattern like in compression atelectasis, so an early and intense enhancement because the vascularization is through the branches of pulmonary artery. But we may have also, in some cases, a late enhancement and weak. This happens when the pulmonary artery is invaded by the tumor. And you see on the graph that in compression atelectasis the arrival time is shorter, but in obstructive atelectasis we may have both shorter times of arrival of contrast agent, but also in some cases the contrast agents arrive very late. In this mass of atelectasis, we may see other lesions like abscesses, necrosis, or even the tumor, because those lesions have a different pattern of enhancement. And you will see in this case, atelectasis, and you see here in arterial phase, at 6 seconds after the contrast agent injection, the atelectatic tissue is enhancing, but not the central part, which takes up contrast later at 13-14 seconds after injection. And in the late phase, at 1 minute, in a venous phase, you see that the lesion washes up, so it may be very easy differentiated from the atelectatic tissue. In pneumonia, we have an early and very intense enhancement because, as you have seen in this movie, because the vascularization is through the pulmonary artery. In some cases of lobar pneumonia, we may have a weak enhancement because we have a vasoconstriction of pulmonary artery. In some cases, and here there is an overlap with the pattern seen in tumors, we have a late and weak enhancement because the contrast agents are rising through the bronchial artery branches, and this happens usually more often in chronic pneumonia, but also in cases when there is a liquefaction of the pneumonia. And here we have big problems in differentiating this kind of lesions from a pulmonary tumor. Another case of a pneumonia, you see here the tissue, a consolidation of the pleura. We have also some pleural lesions. In fact, it was a case of tuberculosis, a big consolidation. And you see here very early at 5 seconds, we have a very intense enhancement of that pulmonary tissue, which represents, in fact, a pneumonia. We have, some authors have detected two fuse patterns in pneumonia with the classical type 1 pattern, which is seen in most of the cases, and this pattern is explained by the pulmonary artery supply with the time to enhancement of less than 6 seconds. And there is the type 2 fuse pattern, where we have the supply to the bronchial artery. Here we have a hyperechoic extent of enhancement and sometimes an unhomogeneous enhancement. And according to this study published some years ago, this type 2 enhancement seen in pneumonia is significantly associated with more complications. 35% of cases, 10%, and is more often seen in younger age. In pulmonary infarction, the B-mode ultrasound reveals more peripheral, posterior, triangular round lesions, and we don't see an alveologram inside the knee. The Doppler ultrasound, the typical aspect is the lack of Doppler signal in the lymphatic zone, and we have sometimes two pleural monophysic signal So these are vessels from the bronchial act. Here you have a case, courtesy of my friend Gerhard. You see a case of pulmonary infarction, and you see that in the early stages after injection, you don't see flow inside the lesion, but after 20 seconds at the periphery of the lesion, you see flow coming. So in the early phases, here we don't see anything. The flow starts approximately with 18-20 seconds here after the contrast injection. So these authors have demonstrated that in pulmonary infarction, usually the increase of enhancement is very, very low in comparison with arterial and pneumonia. We have three patterns of enhancement. Pattern A, no enhancement. Pattern B, inhomogeneous enhancement with areas of no enhancement. And we have homogeneous arterial enhancement. Of course, this is less frequent. So patterns A and B account for 80% of the cases, and this makes these findings very suspicious for embolic consolidation. Pattern C is in fact atypical for embolic consolidation. And these authors have demonstrated that, for example, in small lesions, if the lesions are below 1 centimeter, in 70% of cases we have no enhancement, and only in 10% of cases there is some enhancement in regarding pulmonary tumors, we have malignant lesions that are enhancing weak and late, because we have here a bronchial artery vascularization, and we have hypervascular lesions like met from renal cell carcinoma or lymphoma, so we have a strong arterial enhancement. So, but the differentiation malignant benign is sometimes very difficult, as we will see in the next slide. So let's have some examples here. It's a tumor in the lung, a subpleural hypoechoic tumor with vessels, and you see here with low resistance flow with high diastolic velocities. You see here the Doppler signals. And if we inject contrast, we will see that the contrast agent will arrive into the lesion at 14 seconds after injection. So thus demonstrating the bronchial artery supply, which is characteristic for the pulmonary lesion. And at 60 seconds after injection, the lesion washes out. So this is another very important clue for the tumoral origin of that lesion. This was a case of pulmonary adenocarcinoma. Another tumor, peripheral pleural tumor, this time a little bit more inhomogeneous. When we inject contrast, we see here that the arrival of the contrast agent is in this case earlier than in the previous case at 9 seconds, but the enhancement is not homogeneous. We have areas of less enhancement there, and at 60 seconds also this lesion is washing out. This was a case of epidermoid carcinoma. Another interesting case, you see here a consolidation. You see here very interesting finding. It's a fluid bronchogram, which is characteristic for obstructive atelectasis. When we inject, this was the Doppler study, we see straight arteries like in the phases with high resistance flow, so pulmonary artery pattern, and we inject contrast, and you see that the contrast will arrive at 9 seconds, so below the threshold of 10 seconds. So after this pattern, after this behavior in the contrast this is very well the straight vessels, you may suspect some neuropathic lesion. But we have biopsied these lesions and the finding was bronchoalveolar carcinoma. So it is known that in this type of tumor, frequently we have vascularization through pulmonary artery and not the bronchial artery. So we may find some possible application of contrast agent study in clinical practice, and I have tried to systematize these applications. So to diagnose a large subpleural pulmonary consolidation, complex one, either obstructive atelectasis, large pneumonia with abscesses, and sometimes pulmonary infarction, to try to differentiate between small subpleural lesions, which are benign or malignant, and to use the contrast study in biopsy. Here we have a case of a patient with a mass into the lung. It starts to have fever and productive stuff with pus. So we suspect an abscess. We have injected contrast, and you see that mass is starting to enhance. It was a smoker, and you see that the mass is starting to take up contrast at 30-40 seconds, so bronchial artery supply, but the center of the lesion here was unenhanced. It was with no enhancement, so it expects here to be a necrosis and an abscess. So it was an infected tumor. We did a biopsy from the peripheral part, and a tumor was diagnosed. Another interesting case of a patient with important productive stuff, and this is here the CT picture, and here these liquid areas inside the consolidated lung. In fact, there were very large bronchi in a patient with bronchial disease. And here also you see very well the fluid into the bronchi. But if you inject contrast, the tissue takes up contrast 7-8 seconds after the injection. So it was clearly pulmonary tissue, it was not a tumor, and you see very well the delineation of the dilated bronchi in a patient with bronchial phase. Another interesting case of a patient with a large mass into the left lung, and you see here the mass. You may say based on the ultrasound picture that this part is somehow different. It may be a tumor in the region, in the central part of the lesion. And if we inject contrast, you see that the periphery of the mass is taking up contrast at 8-9 seconds, but the central part is taking later, and with weaker enhancement that the peripheral part, and in the venous phase, you see here that the central part is hyper-enhancing in comparison with peripheral part. So here it was the tumor and this was obstructive arterial phase. Another interesting case of a tumor, and you see we have also some pleural effusion, and you see here that the central part is taking up contrast at approximately 10 seconds, 11 seconds, and the peripheral part is taking up contrast later on. So in here, the tumor was here, and the central part was, in fact, I put it again here, it was a characterization, and later the time of arrival was due to the invasion of the pulmonary abscess. This is better. We have punctured the lesion in that part, and no plastic tissue was bad. In small subpleural lesions, we don't know exactly what they are. Of course, the clinical picture is important. Here it was a case with young adults with this lesion, some pleural effusion. This was the Doppler study, and if we inject this contrast, we will see that the lesion will take up contrast at approximately 13 seconds after enhancement, after injection. So it was suspicious for malignant lesion, but in the tumor space there was not a very important washout. So based on these findings and trying to demonstrate the nature of that lesion, we did a biopsy, and the result was tuberculosis. So this demonstrates that in some benign lesions we have also vascularization through bronchial arteries. So bronchial artery supply does not always mean malignant tumor. Another case of a mass in the peripheral part of the lungs with great vessels. Here we have the flow with high resistance, and we did a contrast study, and you see that the contrast agent arrived in the region at 12 seconds, so a little bit later than usual, and in fact without a clear washout in the venous space, we have punctured also this lesion, and it was chronic pneumonia. Another very small lesion is the peripheral part of the lungs, and if we inject contrast, you will see that that lesion is actually not taking up contrast at all, so it was a tuberculosis. So here are the guidelines of the European Society of Ultrasound from 2011, which are more extensive, written the use of the contrast agent in some lesions, and you may read these guidelines, but also the newer guidelines published years ago. So in that guideline, it was stated that fuse is usually differentiating inflammatory from embolic lung consolidation, especially in patients with equivocal CT findings, and it may be used in cases to diagnose lung abscesses with pneumonia, since use appear better than conventional B-mode ultrasound or PCR. The problem with contrast-enhanced ultrasound in the lungs in differentiated malignant from benign lesions is the fact that the arrival time, which was the main parameter used to differentiate between. So, as in this study, that homogeneous enhancement with contrast agents arriving before 10 seconds is somehow characteristic for benign lesions, and in homogeneous enhancement later than 10 seconds is typical for neoplastic disease. And using that criteria in that paper, it was shown that diagnostic accuracy was 95%, so very high accuracy. Also, there are also other parameters used to differentiate these two entities. Early washout is more frequent in neoplastic disease, and late washout in benign. But in fact, the arrival time of contrast agents depends not only on the nature of the tissue, but also on the hemodynamic situation of the patient. There are patients with heart disease where the arrival time is later, so it may arrive at 10-second arrival second, and thus you may say that the patient has a neoplastic disease. In fact, you should compare the arrival time of that lesion in comparison to the arrival time in the pulmonary tissue, and using that, these authors a couple of years ago have demonstrated that using this comparing the arrival time, we may differentiate very well between malignant tumor and pneumonia. But it's very difficult to differentiate between pneumonia and chronic inflammation, and also using the total enhancement time and the impedance to see here the differences between them are not statistically significant. In lung biopsy, we may use fuse in this situation to avoid necrosis in large lesions, to target tumoral masses in atelectasis, to target abscesses in inflammatory masses, to skip biopsies when it's not necessary, and to monitor complications. Anyway, we try to give an example of each indication. There were some studies demonstrating that in patients with lung masses, the use of contrast enhanced guidance versus US guidance revealed an increased diagnostic sensitivity in this study, 93 versus 78, and this in this study a sampling rate of 100% and diagnostic accuracy of 98%. Is this true for all lesions? This study has demonstrated that total number of lesions, we have a clear significant increase of diagnostic accuracy, so around 16%. But this is not significant for lesions below 3 cm or between 3 cm, but it is valid for lesions larger than 5 cm, which frequently have necrosis. The complication rate is the same. And also, the use of contrast enhanced ultrasound before a biopsy is very useful, because in some cases we may say that we don't perform the biopsy because that tissue is not a tumor, it's a lung consolidation, or we see mass with very high percentage of necrosis. So in that case, we need fuse guidance to target wide edge. And you see here in this example a tumor, a large tumor in the lung, and you see here the extent of the necrosis. So it was 80-90% necrosis. But using the information of contrast, we may insert a needle in the active part of the tumor, and we may sample via the tissue. Regarding the biopsy of central tumors, here is also very good application of contrast enhanced ultrasound, because as I have shown you, with this technique we may detect that lesion. So according to the study, we have a very high rate of successful puncture, but we have more complications because we have to go with the needle through the pulmonary tissue, and you see here in this case, because the case that I have presented before, and we have to go with the needle through that part of the lung and to target this area, which was the tumor. The information obtained, you see here the tip of the needle. The information obtained by contrast enhanced ultrasound is very useful to detect the tumor, but also to avoid a large vessel. In cases with complications, here it was a biopsy in a patient with pleural effusion, and after 10 minutes after the biopsy, the patient experienced some pain in the thorax, and we did an ultrasound and we saw this mass moving. Of course, we have experience in interventional ultrasound, you see that this was a clot, but we tried to inject contrast agent in order to see if the bleeding was stopped or not, and how big is the bleeding. And in fact, we saw that there is actually no bleeding inside. The bleeding has stopped. You see very few bubbles here, probably some drops of blood, but it was not an important bleeding, and this was stopped later. And a very interesting case, it was sent to us for a biopsy. We did an ultrasound, you see this mass, which contains both solid and cystic areas, but it was very round. It was very suspected for tissues for a kind of reason. We injected sonogram, and we were almost sure that this lesion was not a tumor, because it was clearly a vacuum. It was a hydatid cyst, so we skipped the biopsy. We sent the patient back to that diagnosis, and the patient was operated. So, the information sometimes may be very helpful before a biopsy. So, to conclude, in lung lesions, contrast enhanced ultrasound may characterize better the nature of large consolidation. It helps in the diagnosis of small subpleural lesions, but here further studies are necessary in order to detect the threshold of arrival time, or maybe other parameters which may be useful in differentiating those lesions. And it's very helpful in the biopsy of, especially of large pulmonary consolidation. And I thank you very much for your attention.